the taste of international speakers, 38 chair and co-chairs. عين شمس درس non-Hodgkin lymphoma Sherlock Holmes session for the second year by Dr. Iman Rajab. Harry Potter 8th year by Professor Tantawi. Choose Wisely 6th year by Dr. El Alfi. 7 awards. We have 2 new awards this year by Professor Galila Mukhtar and Professor Azza Tantawi. This is my father. Today is the memorial. He 10 years ago he passed away. He was awarded جائزة الدولة التقديرية سنة 90. والحقيقة he is my mentor. يعني كنا نقوم في نص الليل نلاقيه قاعد على ترابيزة السفرة بيشتغل. المكتبة اللي ورايا يعني فيها في كل أوضة كتب، وكانت يعني الشكوى بتاعت والدتي رحمة الله عليها ايه الكتب دي كلها، انما انا اتعلمت حب الكتب وقراية الكتب. الاربعه الكبار اللي في الجمعيه، الاستاذ الدكتوره جليله، الاستاذ الدكتور محمد بدر، الاستاذ الدكتور منصور، والاستاذ الدكتور مجدي الكيابي. ويشرفني انه البريزيدنت بتاعت اول يومين الدكتوره منال حمدي السيد، وسكرتير المؤتمر الدكتوره امير عدلي. السيشن الاولانيه فيها نجوم الحقيقه انترناشونال، هم ناشونال بس كلهم انترناشونال فيجرز. الدكتوره الهام والدكتوره منال، الدكتور عمر حسين، الدكتور شريف وديع، الدكتوره سناء محمود. يعني نجمتنا الحقيقه اللي اتكلمنا على الفاكسينيشن، كل الناس بتتكلم على الفاكسينيشن يعني ولا لما كانوا بيتكلموا على اي رومرز موجوده. ياسمين جمال مش هتبقى معانا، هيبقى معانا الدكتوره نيفين والدكتوره خديجه. بعد الظهر النهارده الساعه 7 non-Hodgkin lymphoma and Sherlock Holmes باي شريف ابراهيم. هو نجم مصري في نيويورك، اشهر استاذ باثولوجي في نيويورك هو شريف ابراهيم، شرف كبير لنا كلنا. الدكتور حماد من 57، دكتوره ايمان عين شمس برضو تاج على راسنا. الدكتور اشرف محمد رجع تاني ان هو يبقى في يونيفرسيتي هوسبيتال، فبقى معانا بقاله سنتين. سلوى في فايزر سيمبوزيوم بعد الظهر النهارده، الدكتوره عزه وانا بساعدها. بكره فول داي هيريديتري انيميا، الدكتوره فاطمه والدكتوره اميره and myself. ونجم النجوم بتاع ايطاليا واوروبا الدكتور انطونيو بيجا، هو احد مكتشفي اهم الادويه لعلاج السراسيم. استاذ الدكتوره وفاء عزت اتكلمنا على الستيم سيل ترانسبلانتيشن وبيفنج ذا واي انه بقت عين شمس على الخريطه بتاع زرع النخاع في مصر. الدكتوره اميره طبعا هي running the questions and answers. هنصلي الجمعه، بعد الصلاه هيبقى الدكتوره نيونيتال هيماتولوجي، والكل كان اكسايتد ان يبقى في سيشن كده. الدكتوره ليلى شريف من جامعه الزقازيق، الدكتور محمد عبد المحسن الاستاذ الخلوق، الدكتوره رانيا الفراش من نيونيتال يونت and myself and moderating is دكتور خديجه. بعد الجلسه دي الساعه 2 الظهر يدق الاجراس المساجد والكنائس للاستماع للهاري بوتر سيشن. الدكتوره عزه بتعمل مجهود خرافي فيها، بتساعدها الاستاذه الدكتوره ايمان رجب. ومعانا السنه دي بروفيسور نايمر من المانيا، برضه ستار كبيره جدا جدا، نائب رئيس الجامعه في الجامعه اللي هي فيها، اعتقد جامعه لايدن او حاجه كده. ونجمه من النجوم وانطونيو بيجا، ومعانا الاستاذ الدكتوره عزه، وثلاثه سبيكرز جامدين، الدكتور مجاهد من المنصوره، والدكتوره هواري من طنطا، والدكتوره نهال حسين من عين شمس. وبعدين تاني سيمبوزيوم دكتور مجدي وانا. وبعد كده دي الصوره اللي فاطمه بتقول دي اللي جابت الكورونا لعمر. انا ما اعرفش ان الصور بتجيب كورونا، يمكن يعني ايه نفكر في طريقه انفكشن جديده. اماني خليل از ايرد وومن، شرف كبير الصراحه، وانا لما اتكلمت معاها وهتبقى حاجه قيمه جدا. وعمر ان شاء الله the impossible could be possible. بعدها جلسه باسم الدكتور التنباري، الدكتور التنباري رحمه الله عليه، وبين الاسفو وبين الورد فيدريشن اوف هيموفيليا. الدكتور مجدي الكيابي هو بيبقى مسؤول عن الجلسه دي كل سنه، جايب لنا رزان قدير من رويال فري هوسبيتال، وجايب لنا نيير اللي كاتب الجايد لاينز في الورد فيدريشن اوف هيموفيليا بتاعت البومبل براند، والدكتوره خديجه، والدكتوره نيفين اندراوس. في سيمبوزيوم بعد كده تاني بتاع تكيدا، بروفيسور جيري دولان من اهم الشخصيات في لندن، الدكتوره منى الغمراوي مديره مستشفى ابو الريش زي ياسمين جمال عندنا. السيشن وانا ازف خبر مش لطيف، السيشن السابعه كان اكتر حاجه انا فرحان بيها، انما لازم هتتعمل الباليشن كير ان بيدياتريك اونكولوجي. يعني سبحان الله اتضمت لنا الاستاذه الدكتوره ايمان زكي، انما الدكتور عمرو الورداني كلمني النهارده انه اتحجز في العزل علشان الكوفيد، فربنا يقومه بالسلامه وندعي له كلنا بالشفاء يا رب. معانا الدكتور صدقي من 57، معانا الدكتوره هبه الشهاوي من عين شمس، والدكتور طعيمه من عين شمس بتاع بين، واشرف محمد، والدكتوره حنان ابراهيم، وطبعا نجوم الشير بيرسون دكتوره جليله وشريف ابو النجا والمجموعه كلها. تشوز وايزلي، يعني وانا رئيس اسم الدكتور مصطفى الهدهد كان بيقول انت متعلق بيها، وفوجئت ان هو السنه اللي بعدها عاملها في الجي اي تي كونجرس بتاعه. هو الحقيقه حسن الاختيار، حسن الاختيار، الشريك، الصديق، الجوب، المحاضره، التوبيك، المرض، التحاليل، العلاجات. فجيمس بوسيل هو واخد الارب نوبل برايس ومرشح لنوبل، هيكلمنا على الاي تي بي، وعندما يذكر الاي تي بي يذكر جيمس بوسيل. وانا هتكلم على الاي تي بي تشوز وايزلي خليفه ليكشر. الف رحمه ونور على استاذنا، ونسال على الدكتوره فاطمه احمد بعافيه شويه. شريف بدوي الحقيقه هو دفعه سنه 2006، نجم من جامعه الزقازيق، طار الى شيكاغو واصبح من النجوم اللامعه. هيكلمنا برضو على 5 اختبارات هيماتولوجيكال تيست نوت تو دو. بروفيسور جيمس بوسيل هيقول لنا اهم محاضره، هو خد الجائزه بتاعه الملك فيصل عشان يعني عنده more than 100 publication in fetal and neonatal alloimmune thrombocytopenia, and Amira Bosel they will run the questions and answer. فايزر سيمبوزيوم بعدها الدكتوره اميره والدكتوره ايمان رجب. روش سيمبوزيوم السبيكر الاستاذه الدكتوره جليله مختار، وانا I am going to run the question and answer. وبعد كده هننتقل الى بورسعيد. فالجزء بتاع بورسعيد هم 2 سيشنز بس، difficult to treat anemia and bioethics دكتوره صفيناز والدكتوره رشا العشري، الدكتوره هدى حساب والدكتور محمد بدر. بورسعيد المدينه الباسله، هنقعد الخميس والجمعه هناك، هيبقى في نوفو سيمبوزيا. والاوردز الحقيقه دايما بيبقى كل سنه في، كان جايزه الدكتور خليفه بقى لها سنين طويله، السنه دي رايحه للهايست بابليكيشن في سنه 2020، واي حد عامل اتشيفمنت في الاي تي بي. الطنباري بقى لها 4-5 سنين، الكيابي من السنه اللي فاتت، انا بقى لي 2 سنين. السنه دي هتروح للهايست اتش اندكس. الدكتوره جليله كان نفسها تبقى معانا السنه اللي فاتت، بس الحقيقه اول ما قلت لها السنه دي وفكرتها قالت انا معاكم في البيست ابستراكس، وفي 2 وينرز، الاستاذه الدكتوره عزه في البيست ابستراكس في اللوكوسايت and phagocyte disorders whatever Gaucher or others, and these are the sponsors. Without them we cannot carry on, and I would like to thank you all. King of Egypt, he is the king of Egypt, Tut, and he would like to thank you all. واسيب الفلور للاستاذ شيرنج، اسيب الفلور للسبيكر الدكتوره الهام، والدكتوره منى جنزوري هتقدمها وتقدم الكود شير هي او الدكتوره منال. دكتوره منى هانم قدمي الكود شيرز، اتفضلي.
مساء الخير. Before I start, I'm sending my sincere and deep condolences to our late Professor Dr. Yahya El-Gamal. He had taught me a lot, among others, in the field of pediatrics. May his soul rest in peace. I would like to congratulate you, Professor Mohsen Al-Alfi and Professor Manal and all hematology and oncology team for organizing this meeting. It is my pleasure to introduce Professor Dr. Ilham Hosni, eminent colleague of pediatrics, allergy, and immunology. She will be speaking about MESI, multiple inflammatory syndrome in children. Dr. Ilham? Dr. Ilham?
unmute. دكتورة إلهام حضرتك على ميوت.
دكتورة إلهام هانم اعملي نفسك unmute لو تسمحي.
هو بس السلايدز بتاعتي do not appear.
لا هم ظاهرين
قدام. هي باينة دكتورة إلهام.
بس I need to see them. بس أنا I need to see them.
ما هم قدامك على الكمبيوتر.
لا they are not. أنا بالنسبة لي اختفوا. Anyway, I will see them from the file.
Okay.
Thank you very much for the introduction. I'm very glad to be with you today to share some data about the immune-mediated storm which we are facing these days from COVID-19 associated MIS-C, or multi-system inflammatory syndrome in children. I have no disclosure. First, I'm going to go through the definition of MIS-C. There are two main definitions, the WHO and the CDC definition. For myself, I prefer the CDC. It is inclusive. It takes the age less than 21 years old, while the WHO stops at 19. The CDC says that the clinical criteria are fever, even for 1 day fever, but 38 degrees centigrade, illness, require hospitalization with more than 2 organ system affected. WHO says it in details what signs that we're going to meet. Of course, the laboratory is important. In the CDC, there is more than one biomarker of inflammation, while it is left without numbering in the WHO. The laboratory or epidemiologic evidence for SARS-CoV-2 infection is important in both, and it says that exposure within 4 weeks with no alternative diagnosis and MIS-C. But a recent report now from Maryland, US, has found a case of a 4-year-old healthy African-American girl who developed MIS-C after 16 weeks of the initial COVID-19 illness. And this is important to most of us because we usually think that after 4 weeks, we are not justified to diagnose MIS-C in the patient who had a SARS-CoV infection. But this case opens a longer period of risk. And of course, the class of cases published on the CDC website from Korea, from South Korea, says that there were 2 main peaks of cases of MIS-C. One of them was in August, last August. By the end of the year, another cluster of cases. The demographics include males are more common than females on the CDC site, and that the main age of presentation, the median age is about 7 years old, so the main age is between 5 and 9 years, although a big number also occurs earlier, in early childhood, 28% of cases in the age group of 1 to 4, and still we have cases up to 20 years old. And concerning the family transmission, I will give you an example of this case report of a family. 2 parents living, healthy parents living in Sweden. They are on the Middle East descent. They are separated, so they have 2 children, 2 brothers and a girl, who spend a month at the mother's home and then a month in the father's home. While they were living with their mother, the index case was the 14-year-old boy who developed symptoms of COVID-19. His serology was positive, but the PCR was negative. He infected his mother, his younger brother, and his 13-year-old sister. The girl developed symptoms for 5 days of fever, GIT manifestations, cough, and upper respiratory catarrh, and she got completely cured after 5 days of illness. The children went to live with their father, and then after weeks of infection in the girl, she developed MIS-C in the form of high fever, continuous vomiting and diarrhea, and skin rash. The father took her to the ER, where she was diagnosed as a case of MIS-C with pancreatitis. The girl received treatment in the form of IVIG and anakinra and also pulse steroid therapy, and she got cured. What's interesting in the case is that the father did infected because he was exposed during the MIS-C illness, not before. The mother was to her son during the SARS-CoV-2 active infection, That's why she got infected. But the father was exposed later on, 4 weeks, when his daughter developed the MIS-C. He was changing her linen every day. He was eating her leftovers from her dishes, but he didn't get infected. And this says that MIS-C is actually an inflammatory post-infectious syndrome. There is active infection at time, so you do not expect that the disease will, because you have seen a case of MIS-C, but rather during the first infection phase. Concerning the pathogenesis, this beautiful article was published lately. The authors called it "Silence of the Lambs," after the famous movie, because the lambs here are the children. The lambs are less than the adults. This is Silence of the Lambs, and later on it can lead to a big cat, which is MIS-C. Why would children have lesser manifestations of SARS-CoV-2 infection? They put 4 points mainly. The first is that cytokine production increases with age, a phenomenon that they call inflamm aging, which causes a subclinical inflammatory state in every elderly person. Healthy children have a great number of natural killer cells, and their lymphocyte levels, as you know, physiologically higher. They have reduced angiotensin converting enzyme receptor on their epithelial cells, which is the main endpoint for SARS-CoV-2 virus. But later on, this silence of the lambs leads to a big catastrophe called the cytokine release syndrome. The cytokine release syndrome of COVID-19 takes one of 3 forms. The first is the MIS-C, the famous in the form of fever, increased laboratory indicators of inflammation, and multi-system inflammation. And there could also be HLH, secondary hemophagocytic lymphohistiocytosis or macrophagation, manifest by hyperferritinemia, high fever, hypertriglyceridemia, and of course hemophagocytosis. Or the third form could be a Kawasaki-like index disease in the form of fever, oral mucosal changes, the conjunctivitis, and the rest. Would a person develop MIS-C while another wants the infection and doesn't develop the disease? It is said that it is the timing between the innate immune system function, adaptive immune system. As you all know, the innate immune system works first when a person gets any infection. It is the first line system that works. And the first indicator is the interferon response. In cases of disease, the interferon response occurs early, leading to a lower viral load. And therefore, when the adaptive immune system starts working after a few days, the viral load has already decreased. So the IgG antibody reaction occurs and there is less inflammation. But in some persons or some children, the disease is severe, including the MIS-C. The innate immune system works with a delay. There is a delay, much time to its function, leading to a prolonged viral load. That's why the adaptive immune system works. It is faced with a viral load that is high, leading to increased production of interleukins and chemokines and more inflammation, resulting in MIS-C. If you'd like to take a closer look, there are 2 case scenarios, the good and the bad. The good scenario is marked by the letter A. Here is the viral inoculation, and then this infection, there is replication of the virus and fever, and then the innate immune system works properly, producing interleukin-1, producing interferon alpha, beta, and gamma in enough quickly in a big amount, and then the adaptive immune system works, producing inflammation, of course, in the form of interleukin-6 and interferon gamma, but the reaction is not severe, leading to inflammation, but this inflammation is deputed or eliminated, by the Treg cells and the cytotoxic T cells. The result will be control of infection. Here is the virus bound by the neutralizing antibodies, opsonization, phagocytosis, the Treg cells work, there is recovery and memory. The bad scenario, here is the inoculation as well. But because of maybe a genetic background or an unidentified environmental factor, the delay in the innate immune system work with less amount of natural killer cells, less interferon response, and less T cytotoxic cells. Within 5 to 7 days, the adaptive immune system will take over. The Treg cells will not be able to perform well because the innate immune system didn't do its job well. There will be much cytokine release. The most important nowadays is the interleukin-1 beta and also interleukin-6 and tumor necrosis factor alpha, leading to severe inflammatory reaction with endothelial damage and alveolar damage, resulting in end organ damage. There will be recovery or death from the cytokine store. This is the whole story between scenarios. The CDC criteria for the diagnosis involve the fever or myalgia with conjunctivitis, lymphadenopathy, stomatitis, erythema, and skin peeling, which I've seen in many cases of COVID-19 emerging into MIS-C. The meningismus, of course, important is myocarditis and cardiac involvement. The GI manifestations are very common in the form of vomiting, pain, diarrhea, and liver enzymes get elevated. The lung involvement is less, and most of it is in upper respiratory tract. But we see cases actually with pulmonary infiltrates and chest pain, thrombocytopenia with neutropenia and lymphopenia occur, and renal involvement. And if you look in this systematic review published in the European Journal of Pediatrics last month, it's about 953 cases. It shows that fever occurs in more than 99% of cases, followed by GIT manifestations. This is the next common. And then cardiovascular manifestations, respiratory are less. Severe illness occurred in 86% of cases and mild in only 14%. And the ICU admission is over 70%, mortality about 1.9% in Europe. I will give you a few case reports that I find in, because I've seen this in many cases. The strawberry tongue that looks like the scarlet fever tongue. And this is published from 47 pediatric patients by the American Dentist Association. And an interesting case from Mexico that which is in an infant who presented with fever, diarrhea, and morbidiform that proved to be MIS-C because his grandfather had COVID-19 2 weeks ago. But we all think that MIS-C is a medium-sized and large vessel arthritis or vasculitis. They looked into the ear of this child and they found some telangiectasia. And therefore, they performed a video capillaroscopy of the skin of the nail folds, and they find ectasia with capillary leak and dilatation of the capillary. And they said that there could be a microvascular defect, not only medium vessels. Another interesting case from South Korea, a 12-year-old boy presented to the ER with fever and severe abdomen, acute abdomen that mimics appendicitis. And before they do the appendicectomy, they took a good history and they found that this boy was exposed to a case of COVID-19 3 weeks ago. So they performed a serum ferritin that was very high. They did an abdominal sonar, showed generalized lymphadenopathy. The largest one was about 2 centimeters with the red arrow. And this was the cause of the acute abdomen. When he was treated like MIS-C, the pain resolved, patient got completely normal, and he didn't need to do appendicectomy because he didn't have one. Concerning the markers, the lab markers of MIS-C, the most important, of course, as we know, the lymphocytopenia. But we should look for neutrophilia because those children have high numbers of neutrophilia. The hemoglobin is below 9 grams. Most cases, thrombocytopenia less than 150, and some of them have less than 100. thrombocytopenia. The D dimer is high, as well as the fibrinogen. In R, the albumin is usually decreased, hypoalbuminemia. C-reactive protein is elevated. Ferritin is above 500 nanograms per milliliter, as well as the ESR. Because the fibrinogen is high, the ESR is high. There is increased, of course, the markers such as troponin and the pro-BMP. This month, or last month in the JAMA, I found a nice piece of work about between severe cases of COVID-19 and MESI. Sometimes we got mixed in the ER. Is this a severe case of COVID-19 or is it actually a MESI? Especially that when we do, before we diagnose organ system involvement, is a high neutrophil to lymphocyte ratio in cases of MESI, a high RP level and a lower platelet count. So you have to look at the ratio between the neutrophils and the lymphocytes. Of course, of cases of MESI will be between the ages of 6 to 12. And more than 70% of cases admitted to the ICU compared to 43% of children with COVID-19, and the mortality in MESI is higher than in severe COVID. The imaging studies, of course, the chest X-ray or the CT scan shows manifestations in MESI in between 20 to 50% of cases, but the most important is the myocarditis diagnosed by echocardiography, decreased ejection fraction as well, pericardial effusion, coronary artery disease, and pericarditis was diagnosed in 4 out of 16 cases in one published case series. Concerning the from the NIH side, quote the note that MESI management decisions should be a multidisciplinary team of pediatric specialists in intensive care, infectious diseases, cardiologists, and pediatric pathology. And I'm proud that this work is published from our pediatric department team. They named it the golden hours because they are actually golden hours. We have to act fast in this case, and it says that judgment should not supersede clinical judgment. The main algorithm for treatment. They have put forward a very good treatment algorithm, and they said that it should be individualized according
2 minutes,
to the
Professor.
patient. Excuse me?
2 minutes,
Okay.
Professor.
Okay. Concerning the treatment, of course, we give antibiotics, but once we have a negative culture, these antibiotics should not. The treatment after the Kawasaki disease in the form of IVIG and aspirin, but we add other anti-inflammatory treatments. This can decrease our use of IVIG and can lead to outcome. And here is a work published in the JAMA this month. It said addition of methylprednisolone therapy, I mean the pulse therapy of corticosteroid IVIG is associated with lower risk of treatment failure, use second-line therapy, need of hemodynamic support, left ventricular dysfunction, and it will lessen the duration stay in the PICU. So we may start methylprednisolone early, hand in hand with the IVIG. This will decrease the amount of IG needed, which is very expensive in a community like ours. Also the anakinra or the anti-interleukin-1. And there is a case series from Switzerland that's published, which shows that if you add the anakinra anti-interleukin-1 TIG, you can decrease the use of IVIG and the cure will be more rapid. I took one patient to them to show you that the first dose of IVIG, there was still an inflammatory response. The second dose decreased it, but not to the baseline. When a dose of anakinra was given, 2 milligrams per kilogram, decreased the inflammatory markers, including CRP, and the second dose went down to the baseline. There are many protocols that use it subcutaneously in the 38 hours, or if the case is severe or complicated by secondary HLH or shock or cardiac failure, you have to use the intravenous route by single injections or continuous infusion. Concerning the question of zinc supplementation in COVID-19, there is no recommendation from the NIH to use zinc above the dietary allowance. It did not prove any benefit in COVID-19. And the question of ivermectin, because this is a subject of debate, there is no recommendation yet on the use of ivermectin, whether with or against, because the trials that are published, the size of most of them are small, and the doses and schedules are not identified. Some controlled trials are open label. Patients were using various concomitant medications, so this leads to confounding, and the severity was not identified. Two questions on the FDA side. Question one, should ivermectin to prevent or treat COVID-19? The answer is no. And is there an emergency use authorization for ivermectin in the US to prevent or treat coronavirus? The answer is still no. And I've seen this yesterday. This is my keynotes. I took it from the CDC side. We should report, we should have a reporting system for every case of MIS-C or suspected MIS-C, in order to identify our own cases in Egypt. And that's what we are doing in the pediatric department. You should consider MIS-C in any pediatric death with evidence of SARS-CoV infection. I would like to acknowledge the pediatric allergy immunology team, which I'm proud to be part of. It was founded by our dear late Professor Yahya Al-Gamal. He has been my mentor for the last 36 years. This is the first presentation I make after he physically passed away. And I can tell you it wasn't easy at all. I used to receive calls from him after every presentation I make, giving me his smart and kind remarks about the presentation to use in my next presentations. Actually, I pray, may Allah grant his every peace and all the mercy for all the support he provided in the pediatric allergy and immunology team and in the pediatric department, for his kindness and for his benevolence. Thank you very much indeed for your attention and your tolerance.
Thank you. Thank you so much, Dr. Ilham. It was a very nice talk. والبقاء لله في دكتور يحيى. دكتور يحيى مش هعوض تاني، يعني هو بصراحة كان أب وكان أستاذنا كلنا، فالبقاء لله. أنا عاوزة أقول لك بس إن أنا استمتعت with your talk. It was a very nice one. Thank you so much. وكنت عاوزة أسألك، ميسي لازم يكون في حرارة؟ لا, I can't hear you.
In 99% cases, there is fever. It's very rare to have a case of MIS-C without fever. And this is the public data so far.
Thank you. I have seen a lot of MIS-C cases this last month, about more than 15 cases. One of them had multi-system affection, chest, heart, kidneys, pancreas, and liver. It was a very severe case, بس الحمد لله يعني now she يعني بتتمثل الشفاء. We start our second speaker, Professor Dr. Manal Hamdi Al-Sayed, Head of Pediatric Hematology and Oncology Department and Director of MASRI. Her talk is about COVID-19 in healthcare workers and Shams University experience. Dr. Manal, اتفضلي.
Thank you very much, Professor Mona, for your kind introduction. Thank you, Professor Ilham, for a great and fantastic presentation. I would like to thank the organizers, Professor Mohsen Al-Alfi, the whole team of the Hematology Oncology for organizing this for the 21st year. It's becoming, it has its whole community, Espho, and of course, Professor Mohsen Al-Alfi has been the founder, and he's still sustaining his activity. And my sincere condolences for the whole department of pediatrics for the loss of a great scientist and a great mentor, Professor Yahya Gamal. May God bless his soul. This is my disclosure, and in my presentation, I'm going to show what Ain Shams University has done and has been leading for the healthcare providers. Just a few slides about the current situation in our region, which is the Eastern Mediterranean region, according to the World Health Organization division of countries. So, so far until the 16th of March, there were 6.9 million confirmed cases of COVID, 6.18 million have recovered, and 151,000 deaths. The attack rate is 952 per 100,000, and recovery rate is around 88.9%. This is different for Egypt, it's around 77.1%, and the case fatality rate is around 2.2%. If we look at the situation in Egypt, Egypt comes fourth among the countries for the case fatality rate. The first actually is Yemen, 24%, and then followed by Sudan and Syrian Arab Republic, 6.3 and 6.7%, and Egypt comes in fourth place in the Eastern Mediterranean region, reporting so far 191,000 cases until the 16th of March. So what about the health workforce in our region? So unfortunately, the density of physician per 100,000 population, per 10,000 population is relatively low, particularly in Egypt. In Egypt, we have a rate of around an average 8.5 per 10,000 physicians, with a class range between 5.1 to 10, and that was in 2017. I think it would be less now. Maybe later we can hear from Professor about the real numbers. The minimum in our 8 and a maximum of 31.3. So Egypt has a low number of physicians per 10,000 population. I think many also have left, fled the country now and left during the past couple of years, traveling to the UK and to Germany. If we look at the Egypt situation, I think we stand after Morocco. It's Djibouti, Somalia, Yemen, Afghanistan, also a low number of physicians per. Ain Shams University has been one of the universities with leading efforts in the COVID-19, with isolation hospitals. The field hospital, the first field hospital in Egypt was Ain Shams University, dedicated a full hospital at Abur for isolation, and also dedicated efforts for management of its employees and its healthcare providers. And this, just briefly, is the workflow in the COVID-19 triage clinics for the university employees. Suspected cases are usually seen between 8 a.m. and patient history examination, or if any of those have chronic liver disease, that they are referred immediately to the emergency room. Stable cases are usually isolated. Medications are dispensed through the hospitals, and the family medicine physicians, they provide the counseling and awareness, particularly for the households. The efforts to diagnose and manage employees, if we look at the numbers that have been discovered since the beginning of the pandemic, total cases that presented to Ain Shams University, 12,824, and the number of deaths, 1,174. But if we look at the last 3 months for the employees, the attack rate, faculty staff 105, assisting bodies 16, employees 95, 11 students, the number of recoveries 175, and 28 mortalities. That's only between December and the 11th of March. There are efforts also in management of employees in the form of research. Ain Shams University has led all universities in the number of research trials that have been registered on clinicaltrials.gov. So we are leading, followed by Cairo University, then Tanta Asyut, among others. This is one of our research studies that started very early in the pandemic, and we called it SARA, for screening and risk assessment of healthcare workers in university hospitals. It was supposed to start at Ain Shams University, and then we follow in other universities, but the study ended at Ain Shams University in 12 hospitals and clinics, including cardiovascular surgery, geriatrics, internal medicine, pediatrics, OBGYN, emergency oncology, psychiatry, toxicology, endoscopy units, and the outpatient clinics. And the scope of SARA, where universal screening, PCR, nasopharyngeal swabs, and rapid serological tests, detection of symptomatic SARS-CoV-2 infections, identifying hotspots for transmission, isolation, and mobilization of the healthcare providers as an emergency measure. So this is the flow chart of the study from recruitment, consent, and then a baseline online survey. And then samples were withdrawn with lab results identified. 21 days later, we had a follow-up survey with samples also provided, and then we provide the lab results. It started on the 28th of April and ended on the 14th of May, 2020. Those were the SARA workstations in each hospital. We had a desk for recruitment and consenting, computers were for baseline survey and the follow-up, and then we had the lab, of course, for specimen and collection. And those are the links. We had the baseline survey, that was an online link, facility infection control, and we had the infection control team on the ground. And then the follow-up forms on day 7, 14, 21. And then, of course, we registered those who were lost for follow-up. This is the first survey that has been published in last August 2020, and the follow-up study has just been accepted to be it's in press. It's currently in press. So we have this one was published for the 4,040 healthcare providers. Those were the key messages. Available evidence of magnitude and risk factors were not available for the low and low middle income countries. They were only available for the high and upper middle income countries. And the key findings in the large universal screening program, and I think it was a very unique program for asymptomatic and symptomatic healthcare providers in resource limited settings. This was fully funded by Ain Shams University, and it really cost significant amount of money in 6 digits. We reported the baseline screening results and the associated epidemiological and clinical risk factors among the 4,040 healthcare providers between 22nd of April and 14th of May 2020 in the 12 public hospitals and medical centers at Ain Shams University. We considered the healthcare worker infected if they were either PCR positive or IgM or IgG positive. And if we look at the combinations, 68.8% were positive PCR. The overall, we had 4.2% who were infected according to our definition. Of those, 68.8%, the majority were PCR positive, 20% were positive only IgM, 6.5% were positive only IgG, and then the rest were a combination, and none were positive IgG and IgM and negative PCR. The infected healthcare providers per hospital or clinic will find that the obstetrics and gynecology department had the highest numbers infected, followed by surgery department, internal medicine, and the pediatric department came fourth, and then less and less for other departments. If we look at the contact with suspected case, 38% said they had contact with a suspected case, 29% said they had a contact with a confirmed case, either as direct care or within 2 meters or for more than 15 minutes, as seen in the bar chart on the right side. Those with pre-existing medical conditions composed around 20% of this population. For the healthcare category, physicians comprised 64%, and the rest were nurses and others. And those working in the ER were 38% of this population. Sorry, my slides are not moving. Okay, so according to the symptoms, we had symptomatic were only 31.8% 8%, and the rest were totally asymptomatic and discovered to be infected. Those physicians, the nurses, were the majority, 57.1% of those who were infected. 16.5% were physicians, and the rest were just on clinical care. These are the highlights of the incidence of what happened in Egypt from the first COVID case that was discovered on the 14th of February. As we can see here, those in italic and in blue are the incidents at Ain Shams University in relation to what was happening in Egypt. So training on the PPEs started very early in the pandemic, and with schools shutting down, air travel suspended, we started reducing the visits in clinics by 50% by the 19th of March. And then the first COVID patient was identified at Ain Shams University Hospital on the 25th of March. Triage at entrance of hospitals later in March, and the first COVID-19 healthcare worker at Ain Shams University was diagnosed on the 4th. With the study starting, we started with the peak, diagnosing many cases with the baseline screening of COVID-19, and then the peak, the first wave, started after the Eid.
Professor, we have 2 minutes, so we have to run.
Yes, so I'll be very swift. From the last contact of a COVID patient, as we can see, the majority had a contact a long time on the left side here before either a suspected or a symptomatic case before they had their COVID or being diagnosed, and a very minimal amount had it within almost 0 days or 1 day. The overall proportion of those among healthcare workers infected, 170 were identified, 8.8% versus 3.4% among symptomatic and asymptomatic. More than 2/3 were asymptomatic, and more than half of the infected healthcare workers did not report any contact with a suspected or confirmed case. Working as a nurse and fever, dry cough, change or loss of smell were independently associated with infection. The infection rate among symptomatic healthcare workers in this study was comparable with the national rate at that time, and we considered most of them as having, rather than nosocomial transmission, a community-based transmission. If we look at the follow-up study, in the follow-up study, we had out of the 170 healthcare workers who were positive at baseline for IgM and IgG, and the rest were negative. We took those rest and tried to follow them up, the negatives. Only 2,282 completed the follow-up study. Out of those, we had a zero incidence of 4.4 got infected during the following weeks. So the incidence of seroconversion was 4.4%, 4% among symptomatic and 5.3 among the the 4% among the asymptomatic and 5.3 among the asymptomatic healthcare providers. More than 2/3 of healthcare workers also were asymptomatic, and the majority confirmed contact with the case for longer than 15 minutes. So the key messages from these studies were the high rate of asymptomatic infections among the healthcare workers, which reinforces the need for expanding the universal regular testing to reduce the risk of nosocomial transmission. And of course, we will need a point of care test that is more accurate than the rapid test that we're currently using to be able, maybe the saliva test or the gum test, or one of those newer tests as point of care, to be able to have a sort of vigilant infection control and follow up the healthcare workers on a regular basis. Of course, Ain Shams University, as of mid-February, started vaccination, and they're doing a pharmacovigilance now for monitoring side effects for both vaccines, the Sinopharm and the AstraZeneca vaccine, and they are monitoring also the neutralizing antibodies. And this is the new study. Hopefully by next year, or by the end of this year, we'll have some good results. Thank you very much, and thanks for all the healthcare workers who contributed to this study, and for being so wonderful in the job and doing the work. Thank you very much.
Thank you, Professor Manal, of course. And Professor Manal is going to present Professor Omar Hussein. Please stop sharing, and Professor Omar Hussein, please start sharing your presentation. Thank you very much.
So it's my pleasure to introduce one of the leaders in radiology in Egypt, Professor Omar Hussein, who's a professor of radiology at Ain Shams University, and he's going to present radiology Q&A. Thank you.
So Dr. Omar Bey, try to share the presentation. دكتور عمر حضرتك معانا؟
أنا معاكم.
على مهلك خالص، هو تحت في الايكون الاخضر.
بس بيقول لي cannot start now. The host has asked you to start.
اوكي. هو حضرتك بتبقى منزلها على السكرين بتاعتك، وبعدين بتدوس شير سكرين.
تمام.
دكتورة هالة هانم منوره. دكتورة هالة هانم منوره الدنيا.
ايوه
انا بشكر الدكتور عمر انه عمل الحركه دي علشان انا موصيه عشان نقدر نشوف حضرتك. اتفضل. هتدوس بس الايكون بتاع ان هي تبقى تمام كده.
Good morning everybody. First I would like to thank the organizing committee and Dr. Mohsen Alfi for inviting me to share this nice meeting with you. Actually, I lost the first. Here we are. My talk today will be about the role of CT chest of COVID-19. I will try to answer some of the commonly asked questions. Since the outbreak of COVID-19 pandemic and along 1 year duration, we examined thousands of patients by high-resolution CT chest and gained a lot of experience. Actually, I'm trying to minimize. Thus, I found it useful to share our experience at one of the radiology centers in Cairo. We had around 10,000 examinations from March 2020 till end of February 2021. 75% showed positive findings, less than 2% were in pediatric age group, and 10% were follow-up cases. We gained a cumulative experience that allows to present an overview of the CT findings and answer some questions about it. Questions to be answered. What are the classical CT chest findings of COVID-19? GGO, ground glass opacities and the crazy paving pattern, progression of disease in infected patients, recovery of disease, vascular changes, pediatric CT findings, chest complications in prolonged infection, accidental findings in asymptomatic patients during other examinations. The classical CT chest findings in adult patients were ground glass opacities called GGOs, consolidation, mixed GGO and consolidation, crazy paving pattern, nodular opacities, and lymphadenopathy, which is very rare. The commonest is the ground glass opacities, which are described in mainly, or first description for it was for COVID-19 cases, which is faint homogeneous lung opacities that show lung vascularity inside. They are subpleural distributed and accompanied by bronchovascular distribution. Starts as rounded in shape, then becomes patchy, and usually starts at lower lobes. Here is an example of such opacities, which are peripheral, subpleural in location, usually starts at lower lobes, and usually they are rounded in their first stage. Then they start to be patchy and still subpleural in location, peripheral, and extends as patches, not as rounded nodules. Crazy paving pattern, which is reticular opacities, linear opacities, caused by thick interlobular and intralobular septations that might be due to interstitial edema and lymphocyte infiltration. When such reticular opacities superimpose on GGO background, it looks like paving stones hence so-called the crazy paving pattern. Such pattern can indicate the progressive course of the disease. Crazy paving is thick interstitial linear bands within the ground glass opacity. Here is the interstitial when it is thickened, so it makes it dense lines within the ground glass opacities. Here are these lines, for example, this one within the ground glass opacity. Here are also linear bands, linear lines, giving as if it is paving of a crazy paving appearance. Consolidation is another stage of the disease, which means increased parenchymal density that conceals the blood vessels. So the progression from ground glass to consolidation can be differentiated by the loss of visualization of vascularity within the opacity. And air bronchogram signs means that the bronchus containing gas is outlined by high attenuation, including both consolidation or GGO. So we can get air bronchogram within both stages. But of course, when the density of the patch increases in cases of consolidation, so the air bronchogram becomes more visible. Generally, GGO, consolidation, mixed, both of them seem all to occur along the time of the disease. Here is an example of faint ground glass patch with internal vascularity, with a central patch of consolidation, another stage where there is consolidation and we cannot see the vascularity inside. So these are two stages of the disease. Another sign is the halo sign. Halo sign is a dense consolidative nodule surrounded by faint ground glass opacity and is more frequently seen in pediatric patients. Sometimes such appearance can be missed with nodule in the lung, pathological nodule or tumoral nodule. Here is the consolidation as dense nodule surrounded by faint ground glass opacity, which is called the halo sign. Vascular changes in COVID-19, vascular thickening is significantly associated with COVID-19 and carries high specificity. Actually, this sign can differentiate COVID-19 from other viral pneumonic lesions. Depending on disease severity, patients having COVID-19 may have coagulation disorders leading to elevated D-dimer levels and increased risk of venous thromboembolism. Abrupt deterioration of patients' medical conditions should raise the suspicion of cardiovascular system complications, and prompt CT angiography could be needed to exclude pulmonary embolism in cases of unexplained respiratory worsening or new onset of chest pain. Here is the appearance of the vascular thickening within the ground glass opacities. Bilateral GGO and dilated segmental and subsegmental vessels. The vessels appear very clear within the ground glass patches of COVID-19. Here is a case of pulmonary angiography showing the pulmonary arteries congested and thickened within the ground glass opacities. Actually, this appearance excludes the presence of pulmonary embolism in such case, which is clinically deteriorated by the extension of the disease and not by vascular abnormality. Progression of the disease. How to know that there is progression in disease? We get increase in the size and or the density of the lesion, affection of other lobes. Usually the process starts at both lower lobes, and when it progresses, it involves other lobes, development of other signs as pleural effusion or lung fibrosis. It is a mild case, early case, and here after 1 week, the patches increase in size and density. Still, we can see the vessels inside, so it is still in the stage of ground glass opacities and not consolidation. Another case of mild degree, patchy areas of ground glass opacities. Now it is changed into consolidation and early cavitation with fibrotic bands. Again, example of how it appears larger, denser, with increased fibrotic changes of the lung tissue affected. And more example of deterioration of case where the patches increase in size, become more dense, and forming consolidative dense mass lesions with starting cavitation here. Again, here is a good example to see the difference between ground glass opacities in early cases changing into dense consolidation in later cases. And here is clearly visible the air bronchogram previously described as linear air filled spaces within the dense consolidated lung tissue. Increasing the size, density, and starting air bronchogram inside. Pediatric age population, children are considered potentially important causes of COVID-19 transmission, as symptoms in children are milder and the clinicians should be aware of taking a definite history of infected family members. The typical clinical symptoms and imaging features are more common in children than adults. Therefore, it is necessary to identify the typical and atypical imaging pattern of COVID-19 pneumonia in the pediatric population. The CT in pediatric patients, atypical findings are more frequent, including nodular unilateral involvement and lymphadenopathy. And also normal exams are also common in spite of positive lab tests. Here is an example of a 21-month-old female positive for showing the classical subpleural patches of ground glassing with the vascularity of the lungs inside, still inside, starting to form a small nodule here. Small nodule in single lobe in a child, 3 years old. This is one of the atypical CT finding in COVID-19 in pediatrics. Another nodular opacity in one lobe in a kid 1 year and 5 months old. What are the complications of COVID-19? The most important is lung fibrosis. Also, we get cavitation in consolidated areas, pleural thickening and adhesions, and pleural effusion. Example of lung fibrosis: when the process of the disease extends for a long time, we get an appearance of destructed fibrotic lung tissue, which requires long-term treatment after treatment of the virus itself. And this will cause a lot of trouble for the patient because of such injury to the lung tissue, which shows a lot of fibrotic bands and bad expansion. Usually another patient where we usually see it in subpleural locations, the same places where it started as ground glass opacities. Here is extensive lung fibrosis. Also, we get cavity at the base of right lung from the cavitation of pneumonia and air fluid level here. Again, cavitating pneumonia with small air-filled space here, and also at the right side. Sometimes you get accidental finding in different examination. The patient has no significant symptoms in the chest, and when he get another exam like this case of PET-CT, we find big patches of consolidation at the bases of both lungs, which appear very hypermetabolic in the PET-CT, and the patient was coming for another reason, as a breast lesion with metastasis in the bones and the liver, and accidentally discovered that she has a COVID-19 extensive condition, although the clinical situation is not corresponding to such appearance. We get hypermetabolic patches and also associated effusion.
2 minutes left, Professor.
Imaging plays a crucial role in the diagnosis and follow-up of novel coronavirus-infected pneumonia. CT is regarded as the preferred imaging modality in the clinically suspected cases and is valuable to monitor imaging changes during treatment. CT can potentially spot people with negative PCR test, but yet highly suspicious of pneumonia regarding clinical condition. CT also provides information about the disease severity. Thank you. Thank you.
Thank you, our dear Professor Omar Hussein, for such wonderful, so informative and illustrative talk about question and answer in radiology of COVID. Thank you for your effort and time, definitely.
Thank you very much.
Merci, Dr. Omar. I'm honored to present our next speaker, Professor Sharif Wadia. Professor Sharif is a professor of intensive care in Ain Shams University, Egyptian Health Minister advice in emergency and critical care. Professor Sharif will demonstrate for us the role of ICU in such COVID pandemic. And تفضل Dr. Sharif, we are all ears. تفضل.
Can you open for me the video camera? You hear me?
Yes, we all hear you.
Yes, Professor Sharif, the video, you can open it from the downward panel, and we can hear you clearly, Professor.
Professor Sharif, there is a green button with share screen.
Yes. 1 minute.
I saw your screen, Professor Sharif.
Yes.
Go ahead.
Yes.
It is clear here.
It's clear. Thank you.
Clear, Professor.
Yes. First of all, I'd like to express my sincere sensation to Professor Dr. Mohsen Alfi, who allowed me to share and to be, I am proud of this with you and to hear me. First, I'd like to say to him, live and remember your father. My talk today, my professors and my colleague, about the intensive care and the impossible mission of the intensive care to face this COVID pandemic. 1 minute, please. ما بيتغيرش عندي.
تمام.
Yes, sir. Yes. Most of what I'm seeing is behind the closed curtain, and the general public isn't seeing this side of it. I'm coming today to talk about the intensive care and the role of this intensive care and the intensivist and the emergency medicine physicians how they are playing a very important role to guard against this pandemic. First, I have to talk about the intensive care before the COVID. In the States, 4 million ICU admission per year with a mortality around less than 20% and annually 500,000 deaths. This year, more than 500,000 deaths alone of COVID in the States. We have to talk later on about the percentage of the admission of the intensive care. 1 patient every 7 of the patients suffering from pandemic, from COVID, required hospital treatment. 1/5 of them have to be admitted to the intensive care. In Stockholm, Sweden, Karolinska is one of the most famous university there and hospital, said that 80% of the intensive care were men, and it's ranged 60% from 51 to 65 years, and the stay in the intensive care was around 11 days. 82% received mechanical ventilator, 14% received renal replacement therapy, and 54% died. We have to remember these numbers because we talk about later on about our numbers in Egypt. This is the weekly number of the new admission to ICU due to COVID. We can see here 2 humps. The first one in the beginning of the March 2020, and then the second one at the end of September till last February, the first wind and the second wind. Our curve may be slightly to the right side, lagging slightly to the right side, and due to the difference in weather between Egypt and other countries, as France and States and Netherlands, this is another curving showing us the percentage of the ICU patient in the ICU. Here, the hump, the second hump of the United States indicate the status of the patient of the intensive care. If we said from 1 minute that in Stockholm it's around 11 days, in the States maybe more, and maybe till 28 days, and this makes the second hump in this curve. First, we have to talk about the presentation of the COVID. We have asymptomatic presentation, mild, moderate, severe, and critical. And these severe and critical are the candidates to be admitted to our intensive care and intermediate intensive care. This is the triaging for case and severity assessment put by the scientific committee of the Minister of Health, and I am proud to be one of the members of this and the head of the department of the Committee of Mortality and Morbidity. Give us the triaging for the suspected and probable and confirmed case. And in the confirmed case, the molecular testing PCR is the diagnosis of acute COVID 100%. So we cannot say that this case is confirmed except after the PCR. The severity assessment makes us to know who is the patient admitted to the intermediate and who is the patient admitted to the high dependency intensive care. The severity, if the saturation, oxygen saturation below 92, hypoxic index below 300, respiratory rate more than 30, and the lung infiltration, as we saw from Professor Dr. Omar, 50%. While if the patient begin to have a septic shock, multi-organ failure, this is a candidate to be admitted rapidly to the intensive care, high dependence intensive care. In the intensive care, our protocol, we have to begin the antiviral and the anticoagulant and the anti-inflammatory. But we have to say point now, we have to try to give the antiviral before the patient enter in the severe and the critical stage. The scientific committee of Minister of High Education put another word, and I am also proud to be one of these members, change the vocabulary and change the presentation by saying the patient presented by incubation period, viremia, and the organ dysfunction. We have to talk about the pathophysiology of the COVID rapidly to take an image about this COVID asymptomatic stage in which the virus admitted to the nerve epithelial cells and bind to the ACE2 receptors. And this stage, the patient begin to be replicated or immunized to be get out, and immunity of the patient respond during this phase. In this phase, there is no possibility of to be infect the patient. The second is the invasion and the upper part of respiratory tract. The virus creep to the upper respiratory tract and begin. The patient suffers from fever, malaise, and dry cough, and this explains for us why it is a dry cough and not protective. In this stage, it is the most infectious stage for the patient. Then it will enter the type 2 alveolar epithelial cell via the ACE2 receptors, and the type 2 alveolar epithelial cell infiltration give us the explanation of why it is affecting, why the patient have beginning to be in the basal and the peripheral, where there is a pendant of the type 2 alveolar epithelial cells. And all of us know that the type 2 alveolar epithelial cells is the cell which responsible precursor for type 1 and type 2. And the cell is the excretory cell for the surfactant. And from here, we can know why there is two phenotypes, L type and H type. And this explains for us why we have some patients suffering from phenotype L type and H type. This is picture show us how the patient enter and stick the protein to the ACE2 receptor, enter to the mitochondria and replicate it, and then it go outside according to exocytosis. also this another one, how it is replicated to be outside, and this is the stages of the cytokine storm, how it affects and leads to multi-organ failure. This is a slide for the presentation of how it is penetrated, mutation, penetration again, multiplication, and exostosis. The patient in the intensive care will take one of the two directions, the cytokine storm or the apoptosis and multi-organ failure. All of us know that no news is good news except for COVID. No news is very bad news. We have 14 guidelines settled all over the world only. احنا عندنا 14 بس. 14 only. First, the three of the presentation. Why it differs from person to person? According to three factors. The severity of infection against a physiological reserve and comorbidity, severity and comorbidity. In another word, the viral overload. Number two, we can care about this. Hello. Is with our hand. Second is the ventilatory responsiveness of the patient to hypoxemia. Not all the patients differ from patient to another to response to hypoxemia. The third time is the time elapsed between onset of the disease and seeking medical advice with what are calling about it now the experience of the disease. Second, the curves of the PCR, IgG, and IgM. And this is settled from the beginning of the COVID. Surviving sepsis campaign at the end of January this year, and this campaign is very important for the intensivist and for the emergency medicine, and all of us know about it, give us 9 guidelines, evidence-based, not changes, which are the use of systemic corticosteroids. We have to give systemic steroids. The use of venous prophylaxis. We are against the use of hydroxychloroquine for severe cases, but we can give it as a prophylaxis. The use of dexamethasone as the best as corticosteroids. Against the use of convalescent plasma except after examination and researches. The use of remdesivir in non-ventilated patients. That's to say, not in ventilated severe cases. So best to start remdesivir before entering in severe and critical cases. Against the awake prone position. Finally, against the empirical therapeutic anticoagulation. The therapeutic anticoagulation is only for the patient with the history of DVT, pulmonary embolism, of cardiac problem. How Egypt faces COVID-19? Egypt faced COVID-19 by 17,000 beds, and it is very satisfactory for us, this number. And Professor Dr. Manel asked about the patients, the number of the worker and the physicians. Yes, it was international number must be around 15 per 100,000 for the urban area and 5 physicians for 100,000 for the rural area. In Egypt, the medical protocols and statistics, what are followed it? No patient admitted to any isolation hospital in governmental hospital, either for the Minister of Health or the Minister of Higher Education, University Hospital, except after the new scoring system. What is the new scoring system? It is a scoring system. We did 8 investigations. And from this 8 scoring, we can give a number. This score, if it is from 0 to 4, it is low risk and this patient can be stay at home. If it is more than 3 and with individual parameter, maybe enter to the hospital. If it is from 5 to 6, the patient can enter to intermediate place, and if it is above 7, it is high dependence intensive care administration. any patient admitted to the minister of our hospital in health or higher education minister university hospital, we did for him intensive care, the Apache 2 score. The Apache 2 score is acute physiological and chronic health evaluation score. It gives us a number, and from this number we can know the mortality and the morbidity of these patients once he is admitted to the intensive care. We follow the protocols of Minister of Higher Education. We follow the protocol of Minister of Health, and for the adult and for the pediatrics, for the pregnancy, we follow the Royal College of Obstetrics and Gynecologically, and we follow our curving is resemble that of France. High number, and followed by down in the middle of this year, and followed by elevation on the end of this year. This is a number in Arabic because I get it from our statistics. It will show us the percentage of the mortality in relation to age group in Egypt. 90 from 60 to 69 are the greatest and the highest percentage, followed by the 50 to 59, and the lowest number was from 10 to 19 years. The percentage of mortality per million in relation to age, the highest for the patients above 80 years, and the lowest between 10 and 19. This is the percentage of mortality in relation to the gender. It's 60% male and 40% female. It differs from the Europe, as we said from the beginning of our lecture, which was 80% for the male. According to for the nationality, 97.7 were Egyptian, other foreigners, and percentage of the comorbidity is very important for us. The patient with no comorbidity and died 14.3% only. Any comorbidity gives us 85.7% of the Egyptian mortality was patients suffering from comorbidity. And this for us is very serious. The patient died in isolation hospital, 85.9% is high to be died in intensive care, while 9% died in the ordinary room, and most of them are suffered from sudden pulmonary embolism or extensive myocardial infarction suddenly, and 6% died in the ER on the arrival. And what we are saying today, we put them 24 hours after admission to the ER. It is more or less a high number, and we try to correct this number because 6% in the ER, we have to correct it. 62% in Egypt, in the intensive care of Egypt, was serving by using the mechanical ventilators, while 37.9 non-ventilated patients. In Europe, it's 82%. Now I am proud to talk about my university, which is Hospital University, Ain Shams University. Ain Shams University, I have to thank our professors and managers about the first wind. They provide service for more than 23,000 patients. 15,500 are patients by using the telemedicine, and with a mortality 4.6% mortality. 55% are of COVID related and 45 are non-COVID related. One of the most important and the first hospital, isolation hospital, university, overall the Egypt was the Abur Hospital. The first wave, it serviced for 867 patients. 83 of them entered direct to the intensive care with a mortality 16.5 and the COVID-related 7.2. The second win was just 518 patients till the middle of January, in the admission of the ICU was 51%, mortality 28%, and the COVID-related was 12.5%. For the second wind, radiologically,
we have 2 minutes. Dr. Shiribi, we have 2 minutes.
Yes. The second wind, 100% of these patients was suffering from bilateral ground opacity and the comorbidity over the 90%. For the treatment, 100% of the admitted to the Abur hospital was took antibiotic and 100% took anticoagulant. For the Actemra, which is for the interleukin 6 inhibitor, 78%, and this is a very high percentage of the cytokine storm admitted. Lastly, the patient 70% was above 60 years, and the condition of the patient on admission, 94% of them are severe and critically. Thank you, sir. Any question? Thank you, professors.
Thank you, dear Professor Sharif, for this lecture and for your tremendous effort in the field of ICU service in Egypt. Thank you, Professor Sharif. I'm honored to speak in the first session of 21st of Espho with such international wonderful panel. My mentor, Professor Al-Alfi, head of our department, Professor Ganzouri, head of our hematology oncology unit, Professor Manal, international, always dear to heart, Professor Ilham Hosni and Professor Sana, dear Professor Sharif and Professor Omar. I'm so honored to speak among such panel. I will share my screen just now. My talk, inshallah, will be about thromboprophylaxis in patients with COVID-19. My objectives will be to answer 4 questions, one by one. The first is COVID-19 is associated with increased risk for venous thromboembolism. Yes, the incidence range from 1% in non-ICU ward to up to 70%. It depends upon maybe the small sample size, the retrospective design, the difference in patient characteristic, the comorbidities, as just mentioned by Professor Sharif, in ward or ICU admission, criteria for diagnostic imaging accuracy, as Professor Omar Hussein said, the diversity in therapies. All of this make the risk change. Definitely. Older, male, obese, cancer, history of previous VTE, comorbidities definitely augment the risk of VTE. So it's very well known by Professor, my mentor, Dr. Ilham Hosni, the mechanism of COVID-19 in the cytokine storm, starting with inflammation, infection, multi-organ dysfunction, DIC, critically ill, immobility, and so on. Such famous figure start like a candle and end by a fire when SARS-CoV-2 reached the AC2 receptor and start the heroic interleukin 1, 2, 6 tumor necrosis factor interferon, like Professor Ilham said, and we'll have a hypercoagulability state with endothelial pathology, together with fibrinogen, thrombin, D-dimer, all of this like a fire, causing micro and macro thrombosis, ending in pulmonary infarction, pulmonary edema, and so on. The American Society of Hematology, the ASH, gathered an international panel to discuss and have guidelines to use the anticoagulation in patients with COVID, whether to use and to compare prophylactic versus intermediate dose versus therapeutic doses, okay, in acutely and critically ill patient. These were the ASH guidelines, and it was updated last February 2021. Let's answer the second question. In patients with COVID-related critical illness, but do not have any confirmed or suspected VTE, should I use prophylactic or intermediate or therapeutic? The ASH guidelines suggest the use of prophylactic intensity, as long as they don't have any suspected or confirmed VTE. Let's define what's the meaning of COVID-related critical illness. They have a life-threatening condition, needing ICU, needing hemodynamic support, ventilatory support, renal transplantation. Third question nearby the second question. COVID-19 related acute illness, don't have any confirmed or suspected VTE. Should I use? Yes, the ASH suggest, and use the verb suggest, not obligation. It's just suggestion till now to use the prophylactic dose, not the intermediate, not the therapeutic. And let's define the acute illness. It's admission to inpatient ward, such as dyspnea, moderate hypoxia, but not needing ICU admission. There were 3 randomized controlled trials, which also study the therapeutic versus prophylactic intensity in such moderate ill or critically ill. And as said, she will update this recommendation as soon as the result will be available in the hand, and also emphasize that clinicians should always weigh the benefit and harms between thrombosis and bleeding. In January 2021, the National Institute of Health announced that full dose, and I highlighted it in red because she mentioned that the full dose anticoagulation is or appeared superior to the prophylactic dose. But until these peer-reviewed data are available, the ASH guidelines has not changed the recommendation about the low dose or prophylactic dose. And they said that risk assessment model to estimate the thrombosis versus bleeding is almost available for all hospitalized patients, but not yet validated for patients with COVID. And definitely ASH panel acknowledged we might use a therapeutic high dose anticoagulation if the patient need so with high thrombotic risk or indication to use any hypercoagulable state. This resume show that ASH guideline panel suggests the use of prophylactic over the intermediate or therapeutic use of thromboprophylaxis in critically ill or acutely ill patient. Question number 4, should COVID-19 patient receive post-discharge thromboprophylaxis? Symptomatic VTE almost 0.6% at 30 or 40 days post-COVID. But the decision should consider the individual risk factor and hypercoagulability, immobility, and so on. Aspirin is currently investigated to give as post-discharge thromboprophylaxis. And also they emphasize about we have to educate our patient about sign and symptom of VTE to seek urgent attention in case such symptoms appear. To select specific agent as thromboprophylaxis, low molecular weight or unfractionated heparin is based on definitely drug issue availability, resources, familiarity. Something very important is that we may use or prefer the low molecular weight subcutaneous every 12 rather than the unfractionated infusion, and it necessitates a lot of staff exposure to COVID patient. Also, there is a patient risk factor. I have to take in consideration my patient, his renal function, if he experienced heparin-induced thrombocytopenia before, any concern about GIT absorption. Definitely this recommendation is not applied to patients who require anticoagulation for such ECMO or something like this. The protocol of Ain Shams University decided, as Professor Mervat Gamal helped me, no role for anticoagulation in patient outside hospital, definitely, except if comorbid condition with hypercoagulability indicated for other hypercoagulable state. If the dimer is above the 100 nanogram per milli, we might use, in COVID patient, definitely we might use a prophylactic dose as I have just mentioned, but if the dimer is below the 100 nanogram per milli, we don't give even. Therapeutic anticoagulation is restricted for those who have a clinical or radiological finding. For example, I'm not feeling their peripheral pulses, or they have evident stroke and so on, or severe progressive renal transplant patient, severe progressive heart or lung disease. In adult, and it will be my last slide. In adults, I'm talking all the lecture.
Professor,
last slide, dear Khadija, last slide. In adult, should we use the therapeutic or intermediate dose in absence of confirmed or suspected VTE? As I mentioned, all hospitalized adults are receiving pharmacological thromboprophylaxis with low molecular weight. If heparin-induced thrombocytopenia, there is history or occurred, fondaparinux is a recommended one. Definitely, if anticoagulation are contraindicated, we have to use a mechanical thromboprophylaxis. And thank you for all my professor and audience and attendees. Thank you.
Thank you, Professor Niveen, for such a lovely illustrative talk. Thank you so much.
Thank you, dear Professor Ganzouri. Thank you, dear.
It is a very important topic. We tackled a very important topic, but I think most of people now are giving anticoagulants for a month after they are discharged, even they have COVID pneumonia.
Yes. And in adult, dear Professor.
It was very clear and illustrative and very nice in every aspect.
Thank you,
so
dear
much.
Professor. Thank you, Dr. Ganzouri. Thank you.
The next speaker.
I'm honored to فليكن ختامه مسك. My last speaker for this session, Professor International Eminent Professor Sanaa Mahmoud, our Professor of Pediatric Ain Shams University. She's a clinical professor of pediatric allergy and immunology in Pikeville, Kentucky, and a lot of international publication and book chapters. We are all ears to hear from you, Professor Sanaa, about COVID vaccination. We are eager to hear. Thank you. اتفضلي بروفيسور.
دكتورة سناء هتنورينا وهتشرفينا as usual.
تسلمي يا دكتورة منى.
يعني الواحد بيبقى سعيد ان انت موجودة في التوك وعارفين قد ايه هنستفيد. Thank you so much.
Thank you بروفيسور سناء. اتفضلي.
Let me share the screen.
هانم, please share your presentation.
I am, but you're not giving me the option to share the screen.
أستاذ محمد, لو تسمح نساعد الأستاذ دكتورة سناء هانم. دكتورة سناء بتكلمنا من أمريكا, وهي قالت أنا هدي الأب تو ديت بتاع النهارده 18 مارس.
تمام.
ولما طلبت منها ابستراكت قالت لي لو بعته لك من أسبوعين هيبقى مش فيري أب تو ديت. اتفضلي.
السلايد اللي بعدها بقى. دكتورة سناء احنا شايفين السلايدز على فكرة.
يا فندم؟
احنا شايفين السلايدز.
ثواني حالا, شايفاها حالا. Let me see the mask. All right. Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Mohsen Al-Alfi and the organizing committee. Thank you, Dr. Mona Ganzouri and all the pediatric department colleagues for inviting me today. First, I would love to express my sincere condolences for the loss of our professor, Dr. Yahya Al-Gamal. May Allah subhanahu wa ta'ala bestow his extreme mercy and forgiveness on his soul. I would love to share with you a little as of today, or actually, I was checking this morning to see what is updated on this. So my disclosures, I have nothing to disclose regarding this presentation. Dr. Fauci said like a couple of days ago, what is the situation of viruses with us? Viruses, we can eradicate viruses like smallpox or simply eliminate viruses like polio, or control viruses like flu. We are living with the flu right now, and this is our hope for the COVID-19 virus. You're going to ask me, when are we going to get rid of this monster? Dr. Fauci also, I'm saying this after him, when we reach 70 to 85% of the world population to be immune. And at this point, the second question is, are we going to decrease the precautionary measures? Unfortunately, up till now, and even after the vaccination, no. why this study was published from Singapore regarding the 4 years compared to last year detection of flu virus. And as you can see, detection and admissions were remarkably decreased during the last year because of the precautionary measures that we're taking for the COVID-19. To this point, how many need to be vaccinated? We are around 7 billion around the whole world. 5.7 need to be vaccinated. In the States, around 200 millions to be vaccinated or immune. This is the biggest vaccination campaign in history up till, as of yesterday, Dr. Mohsen, I was checking till yesterday, more than 400 million doses were administered in 132 countries. Around 9.6 million doses a year, and this is increasing. Let's look at the world map for vaccination. Of course, the intensity of the color reflects the more vaccines were administered, more in the US and Europe. In Egypt, it's fortunately enough picking up. The rest of Africa, unfortunately, is not clear, although some African countries are picking up right now. I want to share with you a little bit of statistics. Also, as of yesterday, in Egypt, around 10,000 and 500, excuse me, close to 500 doses were given in a rate of around 200 doses a year. The statistics say like around 300,000 doses were coming from China, 50,000 the UK type, and another 50,000 from India. What about the States? The States, 113 millions in a rate of around 34 individuals per 100. We are not doing that good in the States compared to UK. In Europe, 27 million doses were given, around 40 per 100. And United Arab Emirates is doing great. Almost 7 million doses were given in a rate of 63 per each 100. And guess where is the best? The best is in Israel. 9.5 million doses were given. Those, by the way, some of them are the first dose and some of them are second dose, but 101.105 per 100. That means more than 50% of their population had received 2 doses of the vaccine. Are we still arguing the natural infection versus the vaccine? We know that the natural infection from all the studies that patients can get reinfected again after 3 months to 5 months. For the vaccine, are we expecting it to last for a year or two? Nobody can ever tell you, but there are studies. What is the duration? For example, this is the Moderna vaccine. They tested 34 individuals for the 2 arms of the immunity, the neutralizing antibodies as well as the cellular immunity. And as you can see here, after 120 days, remarkably high levels, even in the age group above 71 years of age. Memory and cellular responses were not quite yet, the studies are not yet there. So that means this vaccine is effective. All the current vaccines are effective in preventing infection, preventing disease, preventing hospitalization, and even if the patient is hospitalized, it should prevent the admission to the ICU or preventing death. Are we still there with the vaccine? This study, the biggest study that was published also recently from Israel, because they are having the best experience in the vaccination. And as you can see, this is the Pfizer vaccine. They tested after the first dose. This is a really remarkable study. It was published together with here. 2 weeks to 3 weeks after the first dose. Are you protected or not? 7 days after the second dose. You can see here around 50% after the first dose will have protection from infection and symptomatic infection. Around 90% will be protected. Hospitalization after the first dose will be decreased to around 3/4, 87 after the second dose, and 62 severe disease was prevented even after the first dose. So it's not, you're not going to be protected 100%. You might get the disease, and there is no actually switch that turn off and on the immunity. It takes time to develop. And as I will see you, cellular immunity takes time to develop. And 92 will prevent it. They have actually, they studied 500,000 in each group. Only 500 got infected. 72% of the deaths were prevented from the COVID-19. So definitely we have some protection from this wicked virus. This is the genome of the virus. We want to prevent the spread of the virus from one person to the other, because the more the virus will circulate, the more you will end up having mutations in the gene. I want to ask you a question. Do you know how many base pairs in the genome of this virus? 30,000 base pairs. Imagine 30,000. How many you're going to get to change the whole real virus? They estimate around 2 years, maybe the virus will be changed. But this is the UK variant. How many in the genome? Like 1,270 plus in only the S part in the S genome that is responsible for changes of the sequence of the amino acids on top. As of yesterday, the CDC and WHO came up with the classification of the variants as a variant of interest and a variant of concern and a variant of high consequences that will end up having even new studies for the PCR. You're not going to detect it by the regular PCR that's currently available, and you're not going to be protected by neither the immunoglobulins that you developed after the vaccination or the vaccine itself, after the disease or the vaccine. Fortunately enough, all the variants that were discovered in this middle zone, the most common one, 23 mutations in the S protein in the UK variant. That's why it's more than 50% more infectious. It really is attached to the ACE receptor hard. The South African receptor, they have 9 mutations in the S proteins. There are other variants, the Brazilian and the New York, and then yesterday, 2 more variants were discovered again. You're going to ask me, so what's the value of the vaccine? They did this also in a very nice way to examine the effect of the vaccine on the variants. And you can see here against the wild virus, the Pfizer, you tested against the wild virus, the serum given of patient vaccinated, and then the AstraZeneca, there is a decrease in this level for this variant. As you can see, this is the variant, the 531 is the South African variant. It decreased to 7.6-fold up to 9-fold. So but it's still effective. Decreasing the efficacy doesn't mean that it's not working. If you're gonna trust the vaccine, I will tell you have to trust it because all the steps that we already know about the trials, they were only just kind of shortened because simply there are billions of dollars that are spent in the research and technology. And it is a science, and it's a win-win situation between pharmaceutical companies and medicine. They need to work, they need to have money. And then every country, then they said that they are having down to the cost for the vaccine. For example, the AstraZeneca vaccine or the messenger vaccine is actually, the dose is between $3 to $4. I'm not going to talk about the details of the vaccines, but I will tell you something that you need to know. What are the vaccines that were never used before? Those what we call novel vaccine approaches, and the traditional vaccine approaches. The traditional vaccine approaches like the killed vaccines, the protein parts like the flu that we use, the hepatitis B, but the novel vaccines or the new vaccines are the messenger RNA vaccines that I'm not going to talk about today, as well as the viral vector vaccines. If you ask me which is like inducing more robust immune system stimulation, definitely viruses, whether replicating or non-replicating, when it's introduced in the cell, it will actually produce a bigger immunity. My talk today will be restricted to the inactivated vaccines, the vaccines in Egypt, and the live vector, what we call recombinant vector vaccines. All the vaccines, like the natural immunity, they need to stimulate the innate immune system, and it's not enough, because if you stimulate the innate immune system, you're not going to have a memory to fight again. And this is the situation where somebody gets mild infection, then you might get infected again, because cellular immunity needs time, days, in order to go through the details. I'm not going to go through details in this. And then memory cells need to develop. And this, as I said, this process takes at least, we say, a week or two, no switch button between that, because it depends on the age, depending on your immune status, depending on the dose, on everything. In short, when we get the virus, it uses your cell to produce the virus, then the antigen presenting cell, the innate immune system, that needs to stimulate very important killer cell, the CD8, with the interference with the TNF. But not only this, it needs to stimulate the helper cell to help the CD8 and to help the B cell to induce the neutralizing antibodies, as well as the memory cell. You need something to mimic this. What mimics this? Exactly the live attenuated or the inactivated. The inactive vaccines that you're having is really a good vaccine, but only a little difference. If we use the if you use your own cell to produce messenger RNA for the virus, you're gonna use part of the virus to use it. They make sure that there was no retroviruses, and immediate digestion and metabolism of this part of the protein. So there will be nothing actually to fear from attachment to the cell. As I told you, the replicating and non-replicating virus is great, because the virus itself, our cells know how to deal with the virus, and the virus will produce so many copies of itself. So and it's killed, weakened. So your innate immune system, as well as the adaptive immune system, will work the maximum. The subunit vaccines and the virus-like particles, they don't use the cell at all. They go immediately from the circulation to the antigen presenting cell. The inactivated vaccines, we all know them, and we give them for even tiny babies. They are stable, they are safe compared, of course, to the live viruses. But as you can see, when they tell you the efficacy is 70%, is 70% is good? Yes, the CDC actually for the flu vaccine, all the flu vaccines, the efficacy is 50 to 60%. And it is good, we're living with it. And the flu vaccine had prevented death, and that is really working great. So they are poor inducers of the cytotoxic cells. This is well-known fact for it. Large amounts need to be dealt with, so the facility will spend a lot of money. That's why the Chinese vaccine is more expensive than whether the AstraZeneca or the messenger vaccines. They need adjuvants, and the adjuvants are relatively safe. Let's talk about the vaccines that we have here in Egypt. Chinese, they have Sinopharm and Sinovac, and a third one, they kept it actually for their military recruits. India is having 2 vaccines, and they are keeping the second one for their natives as well. And there are other vaccines in the world, we're not going to talk about them. India is really the Bharat Institute of India, the Serum Institute of India, was established in the year 2000. And some of the big budget that is coming from the WHO is funding the Bharat Institute. And that's why they are producing the Covaxin, the inactivated, and the Covishield. The Covishield is the adenovirus, the Oxford AstraZeneca virus. And actually, they are producing this also in South Korea. So England is producing some, and then the rest of it is produced by India and produced by South Korea. Sinovac, the first Sinovac vaccine, they had published stage 3 completed, but they have not published it. And they had it in different places, and each place they had different percentage of the efficacy. In Brazil, they said above 50, Turkey 91, but generally speaking, 91% efficacy. And they published only phase 1 and 2, which is only on a small amount of patients. And they said the cellular immunity is not that much. We expected that, definitely. And they need sometimes boosters. Don't worry about this details, but you can see immediately after the vaccine, there is nothing rising. And this is phase 1 and phase 2, rising very good titers. This is the plant in China. This is the Sinopharm vaccine. Sinopharm vaccine published also trial 1 and 2, they said also good number, and they said neutralizing antibodies and 100%, they had no adverse effect. So are they quite safe? Yes, you can see the jumping titers of the antibodies, and you can see the blue one is the control, and the increasing titers day by day, developing good immunity. It is inactivated vaccine. phase 3 was done actually, and I think it's being done now in Egypt. It's controlled. They registered, as Dr. Manal had said. I did not find the results yet, but maybe they are considering the vaccination itself as part of phase 3. I have no idea. They said the efficacy is 80%. Very good efficacy. Viral vector vaccines, sometimes they have the other name, recombinant vaccines. The only one that had been in the market is the Ebola in Africa, the only vector vaccine. And it has been used. They use different names of the viruses. All of them, whether human viruses or animal-based viruses, they are quite safe viruses. They use the same idea, having the S protein, which is the major pathogenic part of the virus. They have the code for it, the genome, and they make that virus as if it's a code carrying, so that adenovirus will present the S antigen. Same like messenger RNA technique, using the S protein. Other vaccines, by the way, use in a different way. And then that will stimulate your immune system. What do we have here? We have the Chinese CanSino. They kept it for themselves. They are using it. The Indian Covishield, that Egypt had some of it. Russian Sputnik. You know what Sputnik is? Sputnik is the first Amar 1957 that Russia had put it in the space. But that's why they added that, because they had Sputnik 1, Sputnik 2, Sputnik 3. This is the Sputnik virus. And then AstraZeneca vaccine and Johnson & Johnson that had been recently licensed. We haven't started it. They are going to use it by the end of this month. And as I told you, why they use it as a one dose vaccine? Because it's a viral vector vaccine. So it induces a very good immune system response. That's why it's one dose. They published the immunogenicity, also stage 1 and stage 2, and you can see the numbers. And they said, if you're going to ask me the question, I already had adenovirus and I have antibodies to the adenovirus, they checked that with the titers also for the different levels, and they found a very good response compared to the immunity. So why I'm here? What is new? And this also recently published the efficacy for stage 3 that was published, and it was used actually for individuals above 70 years of age. So the adenovirus vaccine was used for all age groups with efficacy around 70%. And even after a single shot, it reduced hospital admissions by 80%. So what's up? The risk factors for DVT and PE. The incidence, I'm speaking in a hematology conference, it's your field. Definitely you know this better than me. It is 1 in 1,000 per year. More in males, more as we increase the age. 2/3 will present as DVT, 1/3 will present as PE and DVT. What about the evolving situation with this recent problem? They had the adenovirus vector vaccine was given to 17 million doses were used, mostly older individuals. 15 cases of DVT reported, PE 22 cases, 7 cerebral venous thrombosis and thrombocytopenia, 3 fatalities. Is it a coincidence? Is it possible or not impossible? But actually, the European Medical Agency, they are supposed to give us the final thought today, but on March 16th, they said the risk outweighs the benefit. The WHO said, fortunately enough, because of their distribution sources, India and South Korea as distribution sources are not linked to the adverse effects. And fortunately enough, Egypt had the Indian part of the vaccine. But definitely, this is a risk that can happen. And the same thing that happened when they had early this published, and then they found that the death rate in the nursing home was the same death rate that happened before even introducing the virus. And this is also in Europe. And up till now, of course, everything has a risk and benefit, but definitely scientists and the art behind it is major. And as I told you, Johnson & Johnson vaccine, by the way, Johnson & Johnson vaccine, this is a multinational company. They have 60 companies and they are going to distribute that all over the world. If you ask me, should I wait? no, we should not wait, because as I told you, we need to stop the circulation of the virus as soon as possible to prevent us from reaching a stage where we cannot find an answer to that. This is
we have 2 minutes to give time for questions and answers.
The final slides. Co-administration with other vaccines, 14 days before and after. Previously infected, better wait for 3 months. For pregnancy, for lactation, in animal studies, no reproduction, fetal or embryonal changes happened. And the Ebola vaccine that was given, no vaccine related stuff. Regarding lactation, in inactivated vaccines pose no risk, but you may choose to vaccinate. And also the WHO and the CDC, they always use it cautiously, except for rituximab, which is the CD for the B cell. You can continue anti-rheumatics. If you can stop the methotrexate, it's all right. Vaccine transplants, unfortunately, recently published the study a few days ago, 500 kidney transplants, they found the antibody only in 17. That means percent. That means that the immunogenicity was decreased. For your immune compromised, you may receive the vaccine, no contraindications, but the safety, potential for reduced immunity, as I told you, will be there. Autoimmune diseases can receive the vaccine, no observed autoimmune or autoinflammatory disorders. Splenic patients, functional asplenia, may still receive, but they might not develop fully protective immune response. And I hope best health for you all. Thank you.
Thank you, Dr. Sana, for this very exquisite talk. You answered all the questions in my mind, at least. I was so afraid from the Sinopharm side effects. Alhamdulillah, it didn't. Can I ask a question?
Go ahead.
Above 80, can we give the vaccine?
It is actually indicated mainly for the above 80 because, you know, the immune system decreases. And that's why even the doses for the flu vaccine, we have 2 doses for the flu vaccine, above 65 and below 65. And then even the shingles, the varicella vaccine, we have 2 doses as well. So supposedly, and maybe you've seen in the first slide that I showed the immunoglobulin levels, it was less in the elderly patients. It was not as much.
Which one do you recommend?
Which form of what? I'm sorry, the question?
Which vaccine do you recommend for the elder people?
To tell you the truth, any vaccine, I will quote this after Dr. Sami Bahna, my mentor, any vaccine is really a good vaccine for now. The inactivated vaccine is a very well-known technique, is an old technique, and it has been used for all the traditional vaccines. But the new vaccines, as I can see now from here, we started having the plateauing. The hospital started decreasing the restrictions, and the number every day is decreasing. Death rate is still there. We are experiencing the 3rd wave because there are other variants, but I can see a change in the mind of everybody taking even the messenger RNA vaccines. America, the US is holding shares in the AstraZeneca 100 million doses. And up till now, they haven't given them the authorization. I don't know why. It's a kind of monopoly game. Is it or something? I don't know. But any vaccine, Dr. Mona, is great.
And for children, Dr. Sana, would you recommend for children?
2 days ago, the Moderna started the vaccine trial for 6 months and above. 2 days ago, as I told Dr. Mohsen, I will wait. The new trial of the Moderna vaccine for the new changing in the S protein, as well as the trial for 6 months and old infants was started. They are going to involve 7,000 kids in that. Up till now, to age 17 only, you can give the Pfizer vaccine. You cannot give any of the other vaccines, even the killed vaccine. They are not given the permission yet.
There is an announcement that today's and this month we are seeing a lot.
Talking about yesterday, I was, you know, there are Bloomberg website that you check up to date, and then also the CDC update, put every day like updates on that, and the vaccine sites themselves, the press, they always update what they're doing every day. And as I said, they are trying. So wait for 3 months. They will have the vaccine after 3 months, most likely.
We are seeing a lot of children having COVID pneumonias.
That's
and Messi. This wasn't in the first wave.
It was not
those days.
محمد يا ريت تشو الفيديو علشان نبقى بنتكلم شايفين بعض. انت انيبل كل الناس.
هو قافل علينا يا دكتور محسن، فمش قادره اتكلم.
ما انا بترجاه اهو، ادي انت قدامك بترجاه. اشكرك يا محمد، اشكرك انك قبلت الرجاء، اشكرك. هو مع اصلك معايا بس مش مشكله، ما دام
احنا سامعين بعض،
احنا سامعين بعض بس مش شايفين بعض. هنا استني بس، هنعرف اول نتائج بعد شهر. هم ابتدوا بالظبط من 3 ايام الاستادي، ابتدوا الاستادي يعني انا كنت مبسوطه جدا. يعني السيفتي مارجن كونهم ياخدوا البرميشن ان يعملوا الراندمايزد كنترولد ستادي في 7000 طفل في امريكا، وبعدين السيت اب ده باي ذا واي موجود في امريكا. وعشان كده الاستاديز لما اقول لك مش فاريبل سيتيز، يعني هي كلها في نفس المكان لانها بتخضع لنفس الاناليسز ونفس الكرايتيريا.
Thank you دكتور سناء for this.
انا عايز اقول حاجه بس علشان انصف الاسترازينيكا اللي احنا كلنا خدناه، لانه في راو عليه جامد. يعني الاستاذه الدكتوره سناء قالت 17 مليون جرعه و3 دايد، يعني 3 من 17 مليون، يعني 1 من كل 5.5 مليون. كلام فارغ يعني حقيقي. والسيريس ادفيرس ايفنتس كون ان هو حصل عليه يعني هولد او بلاك بوكسنج مؤقت في اوروبا، واوروبا هي بلد واحده، 22 بلد دول هم يمثلوا الاتحاد الاوروبي الاي واحنا كنا مع شارلوت نايمر امبارح، انا وخديجه وايمان رجب، وقالت ان هم they expecting within few days ان هو it will come back.
النهارده الاي ام اي عندها اجتماع. انا كنت قبل ما اخش بصيت على الويب سايت بتاعهم، قالوا ستيل هم هيطلعوا الريبورت بتاعهم مارش 18، بس as of مارش 16 قالوا ان الريسك البنفيت outweigh the risk for the vaccine. So definitely this is a strong statement. This is a strong statement.
انا بصراحه معاك يا دكتور محسن ان هو فعلا احنا كل اسم الاطفال اخذوا والحمد لله تقريبا ما حصلش حاجه. يعني فيو جالهم حراره 39.
ما هو ده يا دكتوره منى هانم، انه هم ادوا 17 مليون جرعه. انا التعليق الثاني يا سناء انه الرقم بتاعنا مصر ادت 10,000 جرعه اللي الناس بتتداولها. مصر خلصت ال 50,000 الصيني الاولانيه وبتشتغل في ال 50,000 الصيني الثانيه، واعتقد ان هي جايبه استرازينيكا. يعني قالوا 3 مليون هيجوا في خلال اسبوعين او 3، انما اعتقد انه 100 مليون جرعه، والروسي نفس الحكايه. فاعتقد ان مصر طعمت لا يقل عن 250 300 الف جرعه. يعني على الاقل كتير قوي من الاطباء في مصر طعموا الاي سي يو والعزل والجامعات وكده، وهيئات اخرى كتيره. رقم ال 10,000 غالبا رقم قديم بقاله مثلا شهر. النوت ابديتد.
والصيني افيلبل فين؟ دكتور how can we get الصيني ساينوفارم؟
دكتورة ممكن أرد بس؟ الصيني في خلال أسبوع 10 أيام في جرعة تم الاتفاق عليها فوق ال 800,000 إن شاء الله هيكون افيلبل لكل مصر إن شاء الله. وكان في اتفاق أكتر من كده 8 مليون، لكن اللي هيوفروه لينا دلوقتي قريب حوالي 800,000 في خلال هذا الأسبوع.
ممتاز. هو
حاجة جميلة صراحة.
الإحصائيات مش عارفة.
اسمحوا لي أسأل سؤال لو سمحتوا.
ازي حضرتك دكتوره جليله؟ ازي حضرتك؟ منوره حبيبتي.
منورين كلكم وانا مستمتعه.
ومبروك على المؤتمر يا دكتوره جليله.
دايما يا رب بالخير بيكم. الحقيقه هو سؤالي موجه للدكتوره سناء من ناحيه الانترتشينجينج اوف ذا فاكسين. يعني انا النهارده باخد الاسترازينيكا being available، لما يجي بعد شهر يقول لي لا ده الساينوفارم which is available. هل ده معترف بيه دلوقتي في اي مكان انا كان interchange one by the other؟ لو كان زي ما بقيت الحاجات الفاكسينز لما بنتكلم عن روتا whatever ممكن ان احنا نعمل interchanging، هل ده وارد يا دكتوره سناء؟
الدكتوره جليله، حضرتك منوره الاول.
حبيبتي اهلا بيك، انت اللي منوره دايما ويعني بترفعي شأن المؤتمر.
لا يا دكتوره جليله، التو دوزز لازم ده سيم فاكسين، لكن هي في حاجه، هي انجلترا بعد لان لقوا الافكاسي بعد 1 دوز بالذات من الادينو فيروس واصله لغايه 80%، قالوا ممكن عشان نكفر اكتر ناس ناجل السكند دوز بعديها، قالوا مره 6 اسابيع وقالوا بعد كده ممكن 3 اشهر. الراي اللي اجينست قال لك انت اولا هتفقد المومنتم انك تاخد السكند دوز، زائد احنا بنقول احنا ما عندناش حاجه اسمها الترايلز اتعملت على الشهر، ما فيش حاجه اسمها سويتش اون سويتش اوف للاميون سيستم، ما تعرفش امتى هيطلع انف انتي بوديز في كل سن زي ما بقول لحضرتك، في كل انديفيدوال مختلف. فرجعوا قالوا ستيك لغايه دلوقتي ستيك تو ذا سيم وستيك تو ذا سيم تايمينج ما بين التو دوزز، ما فيش تشينج
ده كان سؤالي الثاني. what is the minimum and what is the maximum duration between the
دكتورة
first
جليلة بعد إذن حضرتك بس عاوزة أقول حاجة، إن أنت بتاخدي الجرعة الأولى هم بيحجزوا لك الجرعة الثانية.
ما أنا بسأل المينيمم تايمينج between the first and second، لأن أنا عارفة فعلا in UK إن هم عملوا postponing for the second dose until 3 months، بس دلوقتي بيرجعوا تاني يقولوا لا this is very long duration. فأنا كنت عايزة أسأل what is the minimum and what is the maximum between 2 doses؟
الترايلز هم كل لغايه دلوقتي they are sticking to the controlled trials اللي هي الشهر اللي موجوده،
تمام.
اللي هي كل الاستاديز اللي طلعت الليفلز بعد ال 28 يوم لما قاسوا بعد 7 ايام، بعد 7 ايام كأن واحد ما اخدش حاجه خالص، يعني لو حد عي وقال انا عييت طب وماله، طب هو الاميون سيستم ما عايز وقت، هو مش فيه النيت اميون سيستم وادابتيف، والادابتيف احنا عارفين انه بياخد وقت، فبالتالي الوان دوز هتدي امتى الاميونيتي؟ مش قبل اسبوعين ل3 اسابيع. عشان كده في اسرائيل لما قاسوا ال 500 في الاول، لان اسرائيل ابتدت اول ناس من اللي ابتدوا واخدوا اكبر كميات فيها، ال 500,000 اللي حللوهم هنا وال 500,000 اللي حللوهم هنا قاسوا بعد اسبوعين وقاسوا بعد 3 اسابيع وطلعوا نسبه ال 50% بروتكشن فقط لا غير. مفيش حد لغايه دلوقتي هنا في امريكا موافق على، وكانوا كذا ابيديميولوجيست بيتكلموا ريسنتلي قريب على انهم ياجلوا 3 اشهر. اوروبا هي اللي كانت بتفكر عشان لما ابتدت الفاريانتس دي قالوا طب ما احنا ندي اكبر عدد عشان نقلل السيركيوليشن اوف ذا فيروس. برضه لا، النهارده حتى الناس لما حتى في تكساس لما جه الجفرنر قال احنا هنقلل البريكوشنري ميجرز ونقلع الماسك ونعمل الكلام ده، مفيش حد عايز يعمل كده خالص. كل الناس نفسها قالوا لا احنا مبسوطين جدا باللي حاصل ده، خلينا اخدين الحرص بتاعنا لغايه الصيف، لان هم اكسبكتنج هنا على 5 اشهر يكون خلصت الحكايه من ديسمبر لغايه مايو. كل بلد ليها يعني ظروفها، بس مصر طبعا سبيكينج اب جريت، وانا شايفه ما فيش بس احصاء اقدر اقولها، لكن اللي بيتعمل حضرتك خدي اي فاكسين، امشي بالسكيدول اللي هم عاملينه وان شاء الله يبقى
دكتوره جليله هنا عاملين سكيدول ان لو ساينو فارم في الجامعه بتاخديها بعد 3 اسابيع، لو استرازينيكا within 3 months، يعني هم بيبلغوهم بعد في ظرف 3 اشهر.
اللي انا كنت بساله يا دكتوره منى، لان انا عارفه ان هو 1 month مش 3 months، فانا عشان كده بقول maybe immunity will wane، لكن هنبقى مرتبطين بالجنرال رولز يعني. اوكي. انا ليا سؤال تاني.
دكتوره سناء ممكن اسال حضرتك سؤال؟ انا
اتفضل يا دكتور. اتفضل.
لا اتفضلي يا دكتوره جليله استاذتنا.
لا اتفضل يا فندم. انا عشان بس انا خايفه من الوقت. اتفضل حضرتك وانا هشوف بعد كده الوقت. اتفضل.
دكتوره سناء كنت عايز اسال العيان البوبيليشن، يعني لما نبتدي معاه بوان تايب اوف ذا فاكسين وخد الجرعه الثانيه، الديوريشن بتاعته من 6 ل 8 اشهر، هل احنا ممكن ناخد another type of vaccine بعد ال 8 اشهر؟ انا بسال هذا السؤال لان احنا كدوله عايزين نحط الناس على epidemiological سيكولي. هل انا العدد بتاعي هيبقى اللي خد السينوفارم لازم يفضل على السينوفارم، خد الاوكسفورد يفضل على الاوكسفورد، ولا بعد كده 6 أو 8 اشهر ممكن نغير؟ لان انا عايز اقول لحضرتك يا دكتوره جليله هانم ان WHO قالت لو واخد نفس النوع ما تغيرش الدوله. يعني حضرتك لو واخد سينوفارم في مصر ما قدرش ياخده في الامارات، مش بس يغير. فسؤالي الدكتوره سناء هانم، هل احنا اللي بياخد نوع لازم يستمر عليه ولا ما يستمرش immunologically؟ يعني دي هتفرق معانا في الاستيراد والدواء وهكذا.
ساينوفارم من اسبوع بالظبط طلعوا ستادي قالوا ان هو افكتيف اجينست البرازيليان فاريانت البي 1. عمل لا دي تيستد، بس هو المشكله في الساينوفارم حضرتك بتاخد كل تشاينيز باخد المعلومات بتاعتهم من الويب سايتس بتاعتهم والبريس ريليز، مش الحاجات الببلشد مثلا في نيو انجلاند جورنال اوف ميديسن او لانست او اي حاجه. كل التشاينيز داتا مع الاسف ستيج، حتى الكنترول ترايلز بناخدها من بقهم هم. انا في كل الفاكسينز اللي هم زي ما بقول لحضرتك الجديده بيستخدموا الاس انتيجين، والاس ده عمال يتغير. الان اكتيفيتد اخد الفيروس لمسم على بعضه، فهل هو كده هيبقى؟ وبعدين حضرتك مستخدم ادجوفنت معين، لان كل مره بيستخدم في ادجوفنت، وبيستخدم طريقه الكيلينج البيتا بروبيونولاكتون اللي هي معترف ان هي السيف، لان البيتا بروبيونولاكتون كارسينوجين في الانيمالز، لكن هم بيستخدموها في دوز الصغيره عشان يموتوا الباتش الكبيره، وبيستخدموا الشمبانزيز عشان يجروا الفيروس. انا تو ماي مايند ما فيش، اولا ما بيتكلموش هنا كتير على الانكتيفيتد بتوع التشاينيز. اعتقد ان ستيك تو 1، لان هي دي مش ان انا احدي الاميون سيستم، كان انا لو اديت بوستر دوز طب ما انا ما اديتش الجرعه كويسه. لان حضرتك لو تعرف هم ابتدوا لما جم ابتدوا ساينوفارم عملوا 3 دوزز الاول، اخدوا 3 دوزز عشان يشوفوا مين فيهم الافكتيف، وهي دي في الستيج 1 و2.
لغايه دلوقتي بيقولوا كده.
لغايه دلوقتي بيقولوا كده، ما هو ما انا بقول
لغايه دلوقتي بيقولوا
لغايه دلوقتي. ما عشان كده الواحد اخد نوع ستيك تو ات لغايه لما تطلع لنا الريزلتس اللي بعد 6 اشهر، نشوف الفاكسينيشن افتر اميونيتي هتلاست فور هاو لونج. هل هتبقى زي الفلو؟ وهل الفيروس هيلحق يتغير تماما؟ هنيجي ما اعتقدش ان الفيروس هيتغير تماما، لانه بعد سنه دلوقتي وكذا شهر لسه ستيل احنا ما وصلناش لفيروس جديد، والتشينجز اللي حصلت زي ما بينت في السلايدز قللت الافيكاسي بنسبه 10% بس. فاحنا وي ار ستيل اون ذا سيف سايد at least 2021 maybe الكلام هيتغير.
سؤالي يا دكتورة سناء على اليوز اوف ادجوفنت، لان لما كنا بنستعمل الانفلونزا اللي هي فلو شوتس، يعني في ناس كانت developing allergy related للادجوفنت not to the flu itself. فهل ده وارد في استخدام فاكسينز ان ساينوفارم فور اكزامبل؟ يعني في ناس دلوقتي بتقول انا لما كنت باخد الفلو شوتس كان بيجي لي الرجي، فهل نفس الكلام ده من الادجوفنت هيبقى موجود في الساينوفارم، ولا مش معروف لغايه دلوقتي ايه الادجوفنتس اللي بيحطوه؟
إذا هنتكلم على الفلو فاكسين، الامريكان اكاديمي اوف بيدياتريكس ايفن قالت حتى لو حد عنده الرجي unless انها انافيلاكسيس بنديه. يعني انا اول ما ابتديت كنت بعمل ديسنسيتايزيشن للفلو فاكسين، كنا باخد واعمل دايلوشن ل1 ل10 1 ل100 ونعمل انتراديرمال تيستينج، واذا كان الرجيك بعمل له ديسنسيتايزيشن اديله 0.05 ل 0.01 0.1 وبعدين 0.2 وبعدين 0.3، وكان بياخد الفاكسينز لانها كل الناس بتدي الفاكسينز لاولادها من سن 6 اشهر. الالرجينيسيتي كانوا شايفينها لانها كانت في الامبريونيتد ايج قبل كده، بس دلوقتي استخدموا سيل كلتشر، ما بقوش يستخدموا البروتين ادجوفنت، هم بيستخدموا السي بي جي موليكيول. دي عباره عن موليكيولز لا يمكن تبقى الرجينيك لانها عباره عن سيكونس صغير جدا. او اذا انا استخدمت الالم فيري انرت، الالم اساسا اللي هو الشبه، الالم بنستخدمه حتى في الاميونوثيرابي بتاعت الالرجي shots الالرجي vaccines. It's an inert substance يعني almost zero allergy to the adjuvant. هو اللي بيحصل لحضرتك بتقولي حد بيجيله ممكن فلو لما ياخد الفلو فاكسين، دي الفاكسين انهانسمنت. اللي بيحصل ايه؟ ان انا اديت جرعه من الفاكسين وانا الانتي بوديز بتاعتي ما هياش نيوتراليزنج انتي بوديز، بايندنج الفاكسين. مع الاسف الفيروس اشطر مني، هياخد يمسك في الانتي بودي ده ويخش جوه السيل ويبتدي يكتر. هو ده سبب ان الناس ممكن يجي لها فلو يقول لك لا انا عمري ما هاخد الفلو فاكسين ده ابدا، لان انا كل ما اخده اعيا. قال لك لانك انت ما عندكش انتي بوديز، بالعكس ده انت تاخده، لان ده هيعمل لك ستيميوليشن للانتي بوديز الكويسه اللي هي عدت على الادابتيف اميون سيستم.
بس اذا كان بيجي له مانيفستيشنز اوف الرجي ازاي هياخده؟
الرجي اعمل له ديسنسيتايزيشن، بس لغايه دلوقتي انا الالرجي انا بعمل البولي ايثيلين جلايكول. انا بعت الفاندربيلت عندي هنا من اوت اوف حوالي دلوقتي احنا وصلنا لعدد كبير من الحالات. عملت اناليسز ل عباره عن 7 حالات هم من المستشفى لقوا انه داوتفول، لقينا الانتي بوديز للبولي ايثيلين جلايكول نيجاتيف. يعني البولي ايثيلين جلايكول ده اساسا موجود في الايه في كل الحاجات الجي اي بريباريشنز. فالبولي ايثيلين جلايكول ممكن حضرتك تعرف ان السوليبريد والميثايل بريدنيزولون في بولي ايثيلين جلايكول، والناس اللي بيحصل لها في ناس يقول لك انا حصل لي الرجي من الستيرويدز، ممكن حصل لك من البولي ايثيلين جلايكول. عند حضرتك ميثايل بريدنيزولون ساكسينيت في بولي ايثيلين جلايكول، معظم الادويه الانجكتبل فيها بولي ايثيلين جلايكول. فالواحد بيعمل سكين تيست ليه وممكن يبعت بلاد ورك يشوفوا. البلاد ورك بتاعي كله طلع نيجاتيف، والعيانين دول اخذوا السكند دوز وما حصل لهمش حاجه. الفاكسين ساعات بيعمل كارديوفاسكولار مانيفستيشنز، ناس بيحصل لهم تاكيكارديا، دي كان بريسيبيتيت هايبرتنشن، هتلاقي حضرتك ريبورتد حاجات دي كلها كانه اخذ الديزيز نفسه. ده يور رياكشن، ده الاميون رياكشن تو ذا فاكسين. لكن هو
حتى لو عنده الرجي مسافر هياخد.
احنا we exceeded our time by 30 minutes. قدامنا ديسكشن رائعه ومحاضره رائعه من الاستاذه الدكتوره سناء هانم. ودلوقتي يعني ستيت اوف ارت ليكتشر والفيري ابديتد انفورميشنز، وحضرتك اديتي طمانينه وثقه لكل الناس ان هي تاخد تطعيم. الدكتوره منى هي بتسال على التطعيم الصيني، وهو ال 50,000 خلصوا، واعتقد ان اللي بيستخدم حاليا 50,000. يعني بعض الجهات اللي انا متاكد ان هي اخذوا الاسبوع اللي فات الصيني والروسي. ويا رب يبعد عننا الكورونا كلنا ويشفي كلنا. وبشكركم جميعا، وهنلتقي الساعه 7. التشير بيرسونز والسبيكرز هنتقابل قبلها بربع ساعه، وكل الاتنديز شكر جزيل لهم، وللاستاذه الدكتوره منى، الاستاذه الدكتوره منال، الاستاذه الدكتوره جليله، all our speakers، الدكتور عمر والدكتور شريف والدكتوره الهام والدكتوره نيفين والدكتوره منال والدكتوره سناء هانم وخديجه. المؤتمر ده من غير خديجه كان لا يمكن يتعمل. خديجه الطنباري واميره عملوا مجهود خرافي، وطبعا كل تيم البيدياتريك هيماتولوجي انكولوجي والدكتوره ايمان رجب. بشكركم جميعا، ونلتقي على خير باذن الله 7 مساء مع شارلوك هولمز and non-Hodgkin lymphoma. Thank you very much. شكرا عمر باشا، الف شكر.
شكرا لكم جميعا، واستمتعت بالجلسه الجميله دي النهارده. الحمد لله.
ربنا يبارك فيك ويخليك يا رب. الف شكر.
شكرا جزيلا لكم جميعا.
الف شكر. شكرا يا فندم.
الف شكر. ميرسي خالص.
ميرسي يا بروفيسور عمر.
الدكتوره منى هانم قعدت الجلسه كلها. الف شكر دكتوره منى، عارفين مشغولياتك. الف شكر.